Fibroids, something painful, something that takes a long time even to diagnose often. Here today is Dr. Katherine Ross from a favorite clinic of fertility answers, Genesis Fertility. I think you're coming in from your hometown of Brooklyn today, aren't you?
That's correct, Alice. I am here in Brooklyn at the office.
That's exciting. Okay, I'm glad to know that you're in the office today. Now, you also have locations, though, for Genesis across the greater New York area. You're in a couple of boroughs, you're lower Manhattan. How many locations total does Genesis have?
We have locations in Brooklyn in our main office and another satellite in Park Slope. We have an office in Staten Island. We have an office in Long Island and another in Queens. So we're not physically in the borough of Manhattan, but we are close by.
Okay, excellent. Now, I wanted to talk today about, a tough topic, fibroids. Fibroids, you're going to define it for us. I won't do that. But one of the reasons I wanted to bring it up is because it does seem like, similar to endometriosis, that a lot of people go undiagnosed for a very long time.
That's correct. So fibroids are quite common. They are benign growths within the uterine wall. And some patients have symptoms like bleeding or pressure or pain, but the vast majority of patients actually do not have symptoms. And we commonly do find them on an initial fertility consultation when the patient was not aware that she had fibroids.
How do you even see it on an initial consultation? Does the sonogram go up that high, or external, internal? How does that part work?
Right. So typically we do both a pelvic exam like you might have at your regular gynecologist office, just feeling the uterus and the cervix. And then we also do an ultrasound, which is typically an internal ultrasound. And with that, we can see the contours of the uterus. We look and see if there's any abnormalities in the contour, either on the outside, the inside, or in the cavity of the uterus, to give us an idea of what type of fibroid it might be.
So women might be struggling with infertility and not really know the cause, but they get to you and then they sort of discover, wow, I don't even have any symptoms of this, but this is preventing implantation from happening.
That's correct. There are some fibroids that may not impact fertility at all, whereas there are other fibroids that can definitely impact the ability for either the egg and the sperm to fertilize in the fallopian tube, or they can impact the ability of the embryo to implant inside the uterus.
So that's a struggle. Why does it seem, though, that it's not frequently diagnosed kind of in your, annual visit with your OBGYN? Aren't women going through the same type of, check-in with their OBGYN that you described, with an internal ultrasound and a pelvic exam?
So some gynecologists do offer that at their annual exam. A pelvic exam, feeling the uterus and the cervix, is considered standard of care. However, ACOG, our governing body, typically doesn't recommend an annual sonogram unless a patient's having symptoms like heavy bleeding or pain. So it's not typically something that your gynecologist should be doing for you at an annual exam unless you have any complaints. But certainly if fertility is on your mind, or if you mentioned that you've been trying to conceive and haven't been successful, the ultrasound is an important tool in the diagnosis of fibroids or other problems that could be affecting your fertility.
And it is a treatable problem if you are diagnosed with fibroids, right?
Yes. So the treatment definitely depends on whether you are trying to conceive or not, because there are some treatments that are contraindicated for women who plan to have more pregnancies. So typically, depending on the size and the location of the fibroid, we discuss whether removing the fibroid or fibroids is necessary for each individual patient's situation.
Got it. Okay, so kind of in this case, size matters a little bit.
Size and location are the key determinants of whether surgery is necessary.
Got it.
There's definitely a proportion of patients who we find the fibroids, but they may just be incidental findings and may not actually be impacting the fertility, and they can remain in place. And we just watch them and make sure they don't grow over time.
And do they ever go away on their own?
Typically not until menopause, at which point, because a woman's hormones drop precipitously, the fibroid then generally shrinks down and becomes smaller and at least asymptomatic. But typically, they don't go away 100%, but they stop causing any symptoms at menopause.
I recall this with this one patient we had through the Fertility Answers platform who mentioned she had already been bleeding really heavily for 6 months. Now, she also was dealing with obesity, and we were so alarmed and so concerned that she let this heavy bleeding go on, for so long without getting into her provider. But on the obesity side, she felt that they wouldn't treat her well, and that she had, never even had her first pap smear. But she did, she was married. She actively wanted to try to conceive. And it was a heartbreaking story. I mean, is that abnormal, her story, or is it more normal than we really know?
I think it's definitely more normal than we really know, particularly the hesitancy to come to the office to be seen, either by a regular gynecologist or a fertility specialist. I see patients frequently who tell me, I've been wanting to do this for months, and they put it off and they put it off. And then finally, once they actually come to the office and see myself or one of the providers, they're typically so relieved that they actually came and are getting answers and support and reassurance. So often it just is a matter of making that first phone call and reaching out to the clinic.
And in today's environment, it is a first phone call, right? Because you guys are accessible via telemedicine. And sometimes just that initial consult, 30 minutes or less, can help them get a lot of answers, not a diagnosis by phone when you have to do a physical exam, but to at least start the process so that they start to feel more comfortable and kind of build a relationship with you.
Exactly. So we've been doing all our new patient consults virtually with telehealth or telemedicine, and we'll continue to do so for the next coming weeks. And then we're hoping we'll be able to resume the diagnostic testing, the ultrasounds, the lab work within the next couple of weeks when it's safe to do so.
Oh, that's excellent. Now, I want to understand surgery and how difficult it is and what the recovery is, so we can address kind of the timing delay that might present in someone's attempt to conceive. So if somebody does need a procedure, is it a difficult one with a long recovery?
That's a great question. So there's different types of surgeries that we perform for fibroids. The term that we give for removing any type of fibroid is called a myomectomy. The fancy name for fibroids are myomas. So in order to remove the fibroids, it depends on the location. So the easiest ones to remove are typically the ones that are within the uterine cavity. With those type of fibroids, we can go in with a small camera. We just enter through the cervix, generally with the patient sedated and having a nice nap. And we can shave out the pieces of the fibroid. This is called a hysteroscopic myomectomy. And those are generally the easiest ones, and typically a patient can start trying to conceive with the subsequent cycle as long as they're feeling well afterwards, which most people do. That type of surgery is done as an outpatient procedure. Patients go back to work the next day or a few days later.
That's kind of amazing.
Yes, so those are the simple ones. The larger ones that are in the wall of the uterus or on the outside of the uterus, those typically will require a more advanced surgery. So if we do a minimally invasive approach, we can do it either laparoscopically, so an incision in the belly button, and then 2 little incisions, or it can be done with what's called a robotic myomectomy. Also a minimally invasive approach. Only if the fibroids are quite large and look very difficult to access would we do what's called an abdominal myomectomy, where we make an incision like a C-section along the
line. Speaking from somebody who did have a C-section, that means it's a longer recovery.
Right. So
a lot of layers to get in there.
Yes, the minimally invasive approach, most patients are out of work for about a week or two,
Hmm.
whereas with the abdominal approach, as you mentioned, the recovery time is anywhere from 4 to 8 weeks, depending on the patient.
Oh, just even thinking about that. Yeah, so that was painful. And I had a newborn to take care of as a single mama. So I will never forget those difficult weeks in recovery.
Yeah.
Now, in these cases, though, a lot of women can go on to conceive without further assistance. What kind of data do we have on that? How many still might need IVF, versus those who then can conceive without medical assistance?
That's a great question. So typically in the patients that have had the more major surgeries, we recommend waiting anywhere from 3 to 6 months to conceive because there is an incision on the uterus similar to a C-section incision. So we wouldn't want a patient to conceive right away and potentially damage the scar that's on her uterus. So what my recommendation normally is at about 3 months of postoperative recovery, we assess the fallopian tubes with a special imaging study that's called a hysteroscopic.
It's one of the longest words we have in the field of reproductive medicine, isn't it?
HSG for short is much easier. I typically will send the patients for an HSG
Mhm.
about 3 months post-op, and that will tell us how the uterine cavity has healed, and it also will tell us if the fallopian tubes are open. And from there, we can guide their treatment decisions. If the patient is young with great egg or ovarian reserve and the fallopian tubes are open, then I do recommend they try on their own for a period of time. However, if a woman is older or has low egg reserve, or if the fallopian tubes are blocked after the surgery or not reopened after the surgery, then obviously we want to start talking about treatment options at that time.
Got it. Now, two-part question is, once the fibroids are removed, is there anything that someone can do from a lifestyle or diet perspective or even hormone balancing perspective to prevent them from coming back? And the second part of that question, of course, is, do we know what causes them?
Right. So there is a lot of controversial evidence on the diet aspect, and the studies are fairly mixed. Potentially, eating a less healthy diet may increase the risk for fibroids. There are some studies that also showed alcohol consumption can increase the risk of fibroids developing. Smoking, surprisingly, no clear evidence that it increases the risk. So typically we recommend, patients live a healthy lifestyle, as we
Sure.
recommend for all our patients in general. Um, and there is a chance that the fibroids can grow back over time, which is another reason why we don't want to give a person, 12 or 24 months to try and conceive on their own without helping them.
Got it. Right. So get to the point where it's healthy to try to conceive so that you don't further delay. Is it more common in younger ages, or is it just, completely across the board with all reproductive ages? And when do symptoms first show up? I mean, when you at the onset of your period, it seems to happen as young as 9 these days, right? So talk a little bit about that for us too.
So the epidemiology studies do demonstrate a clear predisposition for fibroids in African American women. So
Mm.
typically they will present at younger ages with symptoms, normally in their 20s or 30s, whereas it also affects Caucasian women, but at a lower prevalence rate. And so oftentimes they're asymptomatic until later in life, like their 40s and when they're done with childbearing. So it's definitely has some disposition based on race. And we believe that there is some genetic component that accounts for it being more prevalent in certain races than others. So the time of presentation generally is younger in African American women and older in women of other ethnicities.
Now, unless it is causing those kind of severe problems, you mentioned that in the younger ages, there's other treatments that are contraindicated to trying to conceive. but which might be fine. What are some of those, for people who are maybe in the younger years where they're okay with waiting to try to conceive, or maybe they're even teenagers? Are they, medical in nature? Is it suppression of hormones? What is the treatment plan then for them?
Right. So those patients, often we can put them on simple birth control pills, and that will often decrease their menstrual bleeding each month and make their cycles less heavy.
Got it.
The birth control pills don't make the fibroids grow, nor do they shrink them. They just help with the bleeding situation primarily.
Got it. Okay, makes sense. Now, some of this heavy bleeding could even lead to things like iron deficiencies, right? I mean, if you're bleeding for 6 months heavily, I can just imagine that there's other things to kind of look out for. Are there also other risk factors outside of your genetics? Is obesity a risk factor, or other conditions, maybe type 2 diabetes? Are there other things that do seem to increase someone's risk of developing them?
Yes, there are. So it's a little bit hard to piece them all out because often the conditions you describe, obesity, hypertension, and diabetes, exist. So we would consider them to be sort of confounding factors.
Right.
But
Right. Got it.
fibroids are more common in women who are overweight. There is some correlation with hypertension and some correlation with diabetes as well.
Okay. Got it. So it's not so much, a specific diet is the anti-fibroid diet. It's that if things that are, we reduce the risk for, are managed by a healthy diet and a healthy lifestyle, it's not just to also reduce your risk of fibroids, but also if you are trying to conceive, we want you to have the healthiest pregnancy possible. Are there other risks during a pregnancy if somebody has had fibroids and the procedure? Is there any risk for miscarriage or anything that we should know and counsel our viewers on today?
So for patients that have had myomectomies via either the laparoscopic or the abdominal route, because of the incision that's performed on the uterus, we do recommend that they have a C-section rather than laboring and having a vaginal delivery, because we are nervous about the scar that's on the outside of the uterus, and we don't want it to rupture, which could be dangerous for the mom and the baby.
Okay, that makes sense.
Yeah. For fibroids that remain in place during the pregnancy, they can sometimes grow a little bit. So patients with fibroids can sometimes have a little more discomfort as the pregnancy progresses. And depending on the location of the fibroid, they can sometimes sometimes the rate of a breech presentation with the baby's butt being down might be a little higher.
Gotcha. Okay.
Have a harder labor. So it can sometimes affect pregnancy, although typically the fibroids need to be quite large for that.
Mm-hmm. So, I mean, it sounds like one of the most important things is that even if someone works with you in removing the fibroids, but they move on to their OBGYN for a healthy pregnancy, that they have a good relationship with their OBGYN, so that the OBGYN, who is also going to care for them during the pregnancy and during delivery, is aware of their entire medical history, so that they're in it together and can, I think, reduce anxiety for the pregnancy of patients who might be concerned, right? We are constantly advocating for women to speak up for themselves, make sure that they ask all the questions and form a good relationship with their provider. And sometimes that's hard for people,
Yes, I always want to make sure when we have a graduation for our patients, which means we get to send them off to their OB for the rest of the pregnancy, that they're comfortable with who they've been seeing, and they're comfortable with the plan for delivery and the hospital they're planning to deliver at. So that is one of the very important things that we stress to patients, is that they should always ask questions of us, of their other providers, because having information and having knowledge is in the best interest for them, of course.
And I will say probably all infertility patients felt the way that I did. Graduation day was not a happy day. it's a scary day. We're sad. We get so attached to you and the nurses and the staff that, you know, we don't want to move on yet. We understand you're not going to deliver the baby, but that you're for those 9 or, you know, depending on your clinic, right? For those 9 weeks that we get to be under your specialized care, it feels amazing because you're in like that protected bubble. You always have somebody to reach out to. The even doing the shots, even if I did, you know, benign shots or shots that aren't even real, just throughout I think the course of the pregnancy, I would have felt like I was doing something protective. And so I did find that graduation was a little bit more difficult than I expected.
Yeah, so that's why I'm in the office today, is I had a few patients that needed to graduate and have their last ultrasounds with us. So yeah, it's very upsetting, yes, to say goodbye to them, and certainly they often voice their desire to stay with us.
Yes, exactly. Well, another benefit in the IVF setting is the frequency of visits. You know, the frequency. I've even told this to my now 6.5-year-old, you know, who was a day 2 frozen embryo for 5 years before I was able to do a transfer. And I often say to him, I felt like every scan that I got to have was a date with him.
Yeah.
You know, getting to know him a little bit more. And I loved it so much. And you get to do it so much more frequently in the IVF setting than once you do graduate. So yeah. I do understand that difficulty firsthand.
Yes, I think we are much more accessible to our patients than other types of doctors. All my patients have my email. They have an after-hours service line. So we're always available for our patients 365 days a year. And
it's amazing. You know, that really is so unique to our field. You know, it really is. I'm also a cancer survivor, and I didn't, you know, I could email my oncologist, but certainly didn't have that connectedness, you know, with him. You were expected just to call the nurses line. It was always a rotation of who was there. You know, you didn't know who was going to do your infusion, you know, your chemo infusion. So it is one of the special and unique things, I think, when you all decide to become doctors and decide to go to this specialty area. So before we wrap it up today, I would love to hear, you know, what drew you to the field of reproductive medicine, in particular, you know, going to fellowship is not easy. It's not easy to get in. There are very few spots, you know, so even completing a fellowship is an extraordinary feat in our country. So yeah, what led to that? What lit you up about our field in general?
Well, I just loved OBGYN during my medical school rotations, and I loved taking care of women, and I just felt like that was my calling once I had done that rotation. So I didn't have any aspirations beyond that in terms of what type of OBGYN I would want to practice. I thought maybe oncology, in fact. And then just during my residency, the rotation in reproductive endocrinology and infertility was the one that spoke to me. And I had some great mentors in that area, and I thought it was just very interesting and challenging, a little different than just standard OBGYN. And so I just felt like it was something special, and really felt a connection to those patients. So that's why I went on for the fellowship, and I'm very happy that I made that leap and had great mentors along the way.
And now you get to practice in your hometown of Brooklyn, right?
That's correct, yes.
Which is
in Brooklyn, and obviously did my training in other places, but came home to be close to family and friends, and happy to be taking care of people I grew up with. And
that's amazing. That's amazing. That's incredible. Well, I'm so grateful that you came on today. I learned so much. I think that there are probably going to be comments that come in as you know, people start viewing, and if there are any resources that we can send to them. You know, what I do want everybody to know is that, you know, you're available for telemedicine consults right now, and that it doesn't have to be just with people in New York, but certainly because you have this specialized area. I would recommend people who even need a second opinion consult that want to talk about, you know, treatment options. They could probably contact Genesis to get in touch with you for that too.
Of course, yes, we'd be happy to speak to new patients, and yeah, even if it's not about fibroids, whatever.
Yes, of course, because you do a suite of everything. It's not just fibroids, but infertility consults, fibroids, PCOS, endometriosis, full service fertility center. We are so grateful for you all, being in network, and we're grateful for the long-standing care that the Genesis name has provided in market. It has a fantastic reputation. We know some of your former doctors even who relocated to California. We love working with them too. And any resources that we have, I'll always include them in the comments below. You can find this talk, let your friends know. It's on Facebook, Instagram, and on YouTube. Thanks so much, Dr. Ross. Enjoy the rest of your day with all your graduations. It was great to get to know you. Bye.